on addiction and suicide by our very, very eminent Dr. Pratima Murthy, who is the director of NIMHANS. We're very, very thank you for honoring us with this acceptance. We look forward to hearing you. We would like to start today's program by invoking Almighty's blessings. May I call upon our ex-president, administrator, and ex-clinical manager, Mrs. Lata Jacob, to please lead us in prayer. Lata ma'am, over to you.
Thank you. Let us pray. God, our Heavenly Father, we thank you, Lord, for this day and opportunity to gather together for the 8th lecture series in observance of the 50th anniversary of MPA. Lord, we thank you for our guest speaker, Dr. Pratima Murthy, who has so graciously made time to share her thoughts and experiences with us. We pray that you will bless her work, bless her family, help us gain a fresh perspective and understanding through today's program. Lord, we thank you for MPA and all its activities. We pray and place all those attending here today, the organizers, the beneficiaries, into your hands. And we ask this in the name of Jesus. Amen.
Amen.
Thank you, Lata ma'am. May I request our current Vice President and mentor, Dr. Jubilee, to please introduce Medico Pastoral Association to the audience today. May I call upon Dr. Jubilee, please? So over to you.
Thank you, Rohini. If I may first personally thank Pratima for accepting our invitation. I asked Pratima to give us a lecture in the month of June, and I could see how booked she was, so she opted to go in for September. Then for a variety of reasons, things got a little staggered, but we fixed her lecture for this day. The only unfortunate thing about this day is that we don't have our current patron-in-chief, so to say, and the one who's responsible for reviving MPA recently, Professor Mohan Isaac over here. It would have been ideal if Dr. Mohan had been here, because he has been Dr. Pratima's teacher and professor. But to get back to the role Mohan used to perform.
May I request everyone to please mute yourselves? Everyone except Dr. Jubilee, kindly mute yourselves.
In 1964, counseling sessions used to occur at St. Mark's Cathedral. These were initiated by the church's urban industrial outreach mission. In 1969, for the first time in Bangalore, the Alcoholics Anonymous was also initiated by the church.
Please,
by a
host
volunteer
can
group.
mute. Co-host can mute everyone, please. We cannot hear properly. Co-host, can you mute everyone?
And unmute me, please. Rohini, may I continue? Okay, so 1964 and 1969, things were going on informally. In 1971, something that was interestingly called the Suicide Prevention Squad was formed. Now that gives us a very military ring, WRING, but I think the mission was to try and prevent suicide. What was really happening was suicide attempters were being counseled by a group of volunteers who were being trained at St. Mark's Cathedral. And this entire range of activities then came under one umbrella. In 1972, there was a registration of the Medico Pastoral Association under the Mysore Societies Registration Act 1960. Now, the MPA, we are the first NGO in the field of mental health, and the credit for this goes in great measure to the goodwill of St. Mark's Cathedral, but very importantly, not a psychiatrist first, but an obstetrician and gynecologist, Dr. Joyce Siromani, who hit upon the idea of finding some kind of rehabilitative facility, which led to the first halfway home in the country. Suffice it to say, in 72, when this body was registered, we had no premises of our own. In 1975, We were granted a lease for 30 years from Bangalore City Corporation, and the first halfway home was then set up. Instrumental in this was the participation of Dr. S.S. Jayaram, one of the first private practicing psychiatrists and an alumnus of NIMHANS, from where we had Dr. Pratima Murthy. Of course, at the time he did his post-graduation, and then he went on to the US to specialize in general hospital psychiatry. Dr. Jayaram and Dr. Joyce Siromani got together, and they had the goodwill, blessings, and guidance of Professor R.M. Verma. By now, the All India Institute of Mental Health had become the National Institute of Mental Health and Neurosciences. And Dr. Verma, whose centenary was celebrated very, very recently, was quite help to the formation of MPA as well as to the building of the halfway home. In 1988, the Extended Care Hostel, the Navjeevan Hostel, was formed for recovering persons with mental disorders. Now, this was a little different from the halfway home, because from here people could go to their educational institute or their organization where they worked, sometimes factories, sometimes offices, and come back. Otherwise, the care was very similar to the halfway home. In 1997, it was felt that we have the scope for starting a long-term care facility for people recovering with mental disorders. And this part of the organization was called the Jeevan Chaitra. In 2001, a training center and staff quarters were built, and this was largely through the largesse of our then vice president and a very active member, a Jesuit priest by the name of Alzira D'Souza. Father Jovita D'Souza's family were very instrumental in getting a large sum of donation for the MPA. In 2002, we went back to our suicide prevention program, and the Sahay helpline, the first helpline in Bangalore, was formed. In 2005, the leased land that had been given to MPA, the lease was expiring and we needed to do something in a hurry, and the BBMP finally agreed to allow us to purchase this land. For this, Dr. Gladys Sumitra, a former secretary, who had also been a former bureaucrat, helped us a lot. In 2007, we further extended our services by building cottages for extended care for lady residents. In 2014, we started a project for the long supported care, but this project has yet to see fruition. We are hoping that as a memorial to this golden jubilee, from 72 to now, we have completed 50 years, and we hope to see it come to fruition very soon. The range of mental health related activities included suicide attempt counseling, alcoholism, chronic mental illness, suicide well-being and suicide helpline. And because we did not want it to be stigmatized, we call it a well-being helpline, that is Sahay. Activities to raise public awareness really rose from about 2002, when we started observing the World Mental Health Day. And mental health related issues have been all addressed quite effectively at MPA. We are really missing Dr. Mohan Isaac's presence today, but I'm glad that in spite of that, we are going ahead with his blessings. Over to you, Rohini.
Thank you so much, Dr. Bhide. May I now hand over the session for the most important event to our current president, Dr. Joseph George, who has been the Dean of the United Theological College and a senior professor of counseling as well. Over to you, Dr. George, for the main event. May I also request all our participants to kindly be conscious and check whether you are on mute or unmuted. And if you are unmuted, kindly mute yourselves for a better experience of the session. We are requesting this time and again. Please check and please mute yourselves if you find yourselves unmuted. Thank you so much, Dr. George, over to you.
Thank you very much, Rohini. It is, in fact, a very important occasion for us to hear from Dr. Pratima Murthy, very eminent psychiatrist in Bangalore, director of NIMHANS, and certainly we'll follow some protocols. If you may have questions, please write your questions in the chat box, and the speaker will try to follow. We will try to follow up with the speaker at the end. You can also raise questions at the end if you have any important questions, so that we will have a short time of discussion in the end. Now, may I request Mrs. Deepanjana Das, our treasurer, to introduce guest speaker, Dr. Pratima Murthy. Over to Deepanjana Das.
Thank you, sir. It's my pleasure. We are elated to welcome amongst us our guest speaker, Dr. Pratima Murthy, Director at the National Institute of Mental Health and Neurosciences. Dr. Murthy herself, a distinguished alumnus of NIMHANS, is a revered authority on mental health, particularly in the field of addiction medicine. She was instrumental in setting up a state-of-art center for training, research, and treatment in addiction medicine, and was responsible for starting a DM super specialization course here. An international consultant to the UN Office on Drugs and Crime, the International Labour Organization, and the WHO, Dr. Pratima Murthy has also helped improve mental health care through the National Human Rights Commission. She has received several accolades for her work at the state, national, and international levels. And we are greatly honored, ma'am, to have you here with us today. Thank you.
Thank you very much. At the outset, let me thank everyone for having me on this particular program. Congratulations to the MPA on celebration of the Golden Jubilee. And it was so lovely to listen to Ajit. The way MPA has kind of grown from strength to strength, the way it started and where we are today. Thank you, Ajit, for getting in touch with me. Of course, as you mentioned, Dr. Mohan isn't there today, but he sent me an apology saying he's actually in the same continent, although he works in another continent. He's not too far away in Hyderabad, attending a conference. So certainly I would want to acknowledge Dr. Mohan Isaac for many things. Apart from being my teacher, mentor, he has also contributed immensely in the area of trying to understand addiction and the complications that occur with addiction. It was very nice to see Lata, Hema, several other familiar people online. I'm sure if all your videos came up, I'd recognize many of the people here in today's audience. It's also very nice that MPA has taken upon itself to do this entire Golden Jubilee series. Golden reminded me of the fact that I need to share with all of you, especially since Dr. Varma and his centenary year were mentioned, that next year we start the Golden Jubilee of NIMHANS. And in fact, we start off the celebrations in December this year because the Neuro Center was built in December 1973. So for those of you who are familiar with NIMHANS, Dr. Varma was very instrumental in actually setting up and building the Neuro Center. And next year, we will be looking at the Golden Jubilee of NIMHANS beginning. And this was developed by the, by the mental hospital, the government mental hospital that existed on the premises since the 1930s, as well as the All India Institute of Mental Health, which was the first postgraduate psychiatry institution in the country. So both these were amalgamated to form NIMHANS. But it's also next year, the beginning of 70 years. And I know some people call the Platinum Jubilee at 75, and some do it at 70. So for example, when Queen Elizabeth, last year was her Platinum Jubilee of 70 years. So we are having our Platinum Jubilee of the All India Institute of Mental Health as well, starting next year. So lots of things to commemorate. But on that note, let me start the subject of my talk this afternoon, which is really to talk about suicidality and the use of substances, so that we try and understand how common it is with the use of substances. What is it that we need to look for? We'll start my presentation and hopefully to try and see how we can reduce both these, which are both individually problems by themselves, but when they are combined together, it is what I might say a lethal cocktail. And let's look and see what are the various nuances that we need to understand as far as substance use disorders are concerned. just get the slides up in a moment. So I hope all of you can see the slides. And we're going to go to the next slide now. So I'm going to talk to you about this. Let's go to the next slide, please. So I want to say that suicide itself, I mean, I think the first and most important thing is to understand how the kind of nature of suicide. And in fact, I remember last month that there was a debate at the World Psychiatric Association as to is suicide a biological disorder or a social disorder. The fact is that it's a very complex problem. And of course, there are biological reasons as to why a person may be more prone to try and attempt suicide. But equally, there might be stressful factors in the environment and socio-cultural factors which might drive people to suicide. And COVID has been a typical example where people who were otherwise not vulnerable are actually more prone to becoming helpless, hopeless, and suicidal. And when you look at the kind of complexities in this diagram that you see, you'll see that suicidality, whether it is self-harm or suicide, is influenced by several factors. On the left of the screen are genetic and biological factors. We do know that some people are more prone than others, especially in the context of a psychiatric disorder, to become suicidal and to harm themselves. But we also know that negative life events and severe social problems lead to psychological distress, and pessimism can also lead to hopelessness. And helplessness and hopelessness are some of the indicators for feeling that life is not worth living and feeling that it's better to take one's life. Equally, factors such as impulsivity, and we know that some people by temperament are more impulsive, they want immediate gratification, they have difficulties in anger management, and people like that, or who feel extremely negative very easily, are also perhaps more vulnerable to thoughts of self-harm or suicide. And of course, we know that external influences, when you see, one talks about copycat suicides, that when you actually witness a suicide and talk too much about it, there is often a phenomenon in society where you see, one kind of causes the other and perpetuates the other. And media influences and media reporting are also very, very important in, influencing this behavior. And of course, access to various methods of suicide are also important. And we know that the outcome of a suicidal attempt, depending upon the lethality of the attempt itself, can lead to an outcome of suicide or a bailing out at that point in time. So it's very, very important to understand that suicidality is not a simple phenomenon and has several factors underlying it. The next slide. So unfortunately, India has one of the highest number of suicides in the world. And that's a statistic that we are very concerned about. And sadly, in India, it's the leading cause of death among young people. Young people between the ages of 15 to 39. And unlike the West, where there is a male preponderance of suicide, in India, there is a female preponderance of suicide. In the Western countries, more men complete suicide, whereas women are more associated with self-harm, whereas in India, it is more common among women. And in the southern region, both genders are highly vulnerable to suicide in terms of the potential risk to die from suicide. Now, in terms of the country's distribution, you'll see that certain parts of the country are more vulnerable, and you'll see that the southern states, which are marked in red, have possibly the higher rates of suicides per 100,000 population, the NCRP has released some of these numbers. Now, and that is sad because the southern states actually perhaps have people with higher levels of education, with better incomes. So it's ironical that as you move up in the socioeconomic ladder, you're also perhaps more vulnerable to several other adverse psychological outcomes. And that tells you that while there is an association between poverty and suicidality, there is even people who are highly educated or in good jobs, because of various kinds of pressures, may be more vulnerable to suicidality. Now, one important thing that has emerged in terms of the relationship between substance use disorder. Substance use disorder is something that we talk about as a general expression for not just the so-called legal substances like tobacco and alcohol, but also illicit substances like cannabis, like heroin and other opioids, like inhalants, as well as pharmaceutical drugs like benzodiazepines or opioid painkillers. Whichever drug you talk about. And I'm only going to talk about the chemical substances of addiction and not so much about behavioral addiction. We can have a discussion about behavioral addiction a little later. But the fact is that individuals who use substances are likely to have 100% increase in having suicidal ideations, in making a suicidal attempt, and the risk of finally dying by suicide is 50% higher than people who don't use substances. Straight away, you see that there is a very, very direct relationship between the use of substances and the risk of an attempt or a completed suicide, which is something that we all need to be very much aware about. The National Mental Health Survey tells us that there is an increased risk of suicidality, which is about 6-fold in people who have alcohol use disorders compared to those who don't. Alcohol use disorders, it embraces a whole range of use, from what is called harmful use of alcohol to addiction to alcohol. And people who have these disorders have an increased fold. And with every other drug, this risk perhaps increases further. So it is generally said that there are 6 to 7 times, and as I showed you in the previous slide, use of substances increases the risk of suicide by 100%. Several studies have suggested that people with alcohol use disorders, at least 2/3 of them have had a suicidal ideation in the past 1 year. A large number of them have had ideas that it's better off to die or, to deal with the pain. A few years ago, we looked at substance use among women. This was something that was supported by the United Office on Drugs and Crime, where we looked at both women who were using substances themselves and women who were partners of men who were using substances. Women who were partners of men using substances had about 40% of them had depression, and a significant number of them had thought about dying or ending their lives. Women who use substances, nearly 70 to 80% of them had suicidal ideations, and a significant number of them had made suicidal attempts in the past. So for women, there is an even increased risk of suicidality when they have a concurrent substance use disorder. And that's very important to remember. How do we make an assessment for suicide? What are the warning signs? What are, the fact that people make plans? They actually, might have attempted it. What are the risk and protective factors for suicide is something that it's important to be aware of. When you look at the risk factors for suicide, there are certain factors that help to determine a greater risk to suicide in future. That includes previous attempts to end one's life, a family history of somebody having died by suicide or having made a suicide attempt, a tendency towards impulsivity. Impulsivity basically means you can't control your urges. You want to do something, it has to be done immediately. People who engage in reckless behavior, driving without a helmet, driving recklessly, not maintaining speed limits, not wearing their seat belts, and trying to overtake. All of these are examples of reckless behavior. Now, childhood maltreatment, or what we call adverse childhood events, have shown to be important risk factors across all psychiatric disorders, substance use disorders, as well as suicidality. So then you must understand, therefore, that independently, many of these are risk factors for suicide. When there is a concomitant use of substances or a risk for psychiatric disorder, and when all the three occur together, psychiatric disorder and substance use and a family history, the chances are likely to be triple-fold or even higher when it comes to suicidal risk. And of course, we also know that chronic physical illness and terminal illnesses are also associated with the risk of suicide because of the chronic pain, because of the associated psychiatric symptoms that go with it. But in addition to these static factors, there are also dynamic factors, and especially acute stress, acute financial depression. I mean, I think we would have read about one of the owners of a coffee chain who, in the throes of a sudden financial crisis, ended his life, died by suicide. Family problems of a significant nature and a family crisis, relationship problems, acute relationship problems are also risk factors. Isolation. Now, particularly COVID and post-COVID, when people had bereavement and felt a sense of loneliness, being cut off from life, that was a significant time where we've seen increases in suicides. And ongoing mental illnesses, particularly depression, is definitely associated. And when people have access to lethal means in our country, organophosphorus compounds, which are used in pesticides, have been one of the major risk associations with suicide. Access to medication. Of course, in Western countries, firearms are very, very common, but they're not unheard of in our own country. We do occasionally read about newspaper reports of people, dying by, use of firearms. The other very important risk factor, which is the topic of today's presentation, is the consumption of alcohol and other substances. Now, it need not be only an addiction to alcohol and other substances. Even an increase in its use has been shown to be associated with suicidality. And of course, people who don't reach out for help are also perhaps very vulnerable to have a lethal outcome from suicide. But there are equally protective factors. And I think as a community, we also need to focus on strengthening protective factors for suicide. And that includes a desire to overcome the current problem. So basically not feeling helpless and hopeless, but believing that if all the doors are closed, there's still one window open, and to feel optimistic about the future, a willingness to reach out and seek help. And that is why it's very, very important for us to, in mental health literacy, to make sure that people know that they can reach out even when everything seems to be completely hopeless, that it is possible to get out of that situation, and they will also be able to get out of that feeling of helplessness if they get help. Family affiliations are also very important. I know young mothers who have said that, they felt suicidal, but the fact of having to be responsible for their family sometimes was a protective factor against actually doing something like that. There is no doubt that social support is very, very important. traditionally from families, but equally from friends, from colleagues, and therefore at workplaces, good social support is sometimes a protective factor against suicidality. Strength or the ability to cope and solve problems, as well as overcome relationship difficulties, getting support from counselors, doctors, and other healthcare professionals, and having a positive experience from care so that even when you feel like completely down in the dumps, you feel that there is somebody who can help you. And of course, strong cultural and religious beliefs that discourage taking one's life are also protective factors. And I think these are something. So the danger of, what I said about media reporting, etc., and making suicide, a kind of understandable phenomenon has the risk of normalizing this behavior. And that is true even of substance use disorders. In society, sometimes when you normalize these kind of behaviors, you also encourage the outcomes, the adverse outcomes of these behaviors. Therefore, denormalizing these kind of activities in society, telling people that's not a good way of dealing with situations, can be very important. And having strong religious beliefs has also been shown as a protective factor. Of course, doesn't protect all the time. None of these factors are 100%, guarantee of protection. But certainly, when they're all there together, they reduce the risk relatively of suicidality. I mentioned the verbal signs of suicidality. I'm mentioning this because we have to look at these in the context of substance use, and I'll come back to what happens in substance use, which makes people, have experienced all these. And one of the verbal signs is, talking about ending life, feelings of guilt or sinfulness, and that particular factor can be very strong if guilt and sin are something that are very deeply ingrained. So while I said religion can be a protective factor, equally, guilt and sin can be risk factors for a person to feel like life is not worth living. Hopelessness and feeling that there's no reason to live, and talking about feeling trapped or not being able to escape from a particular situation, talking about being a burden to others, these are important signs of a subjective distress. And drinking, using substances more than before, feeling restless and agitated, feeling very worried and fearful, sad and dejected, not sleeping at all or oversleeping, a lot of change in the eating habits, extreme degrees of withdrawal can be signs both of depression as well as suicidality. It just basically suggests that a person is very distressed and needs a little greater attention. As I said, being isolated, being extremely angry, displaying extreme mood swings. And we call these as preparatory behaviors. That means a person who gives away their belongings, is collecting medications and hiding them away, is collecting other methods, pesticides. These are all what are called preparatory behaviors, and they may be warning signs of an imminent suicide. Why do substance users, whether it's alcohol users or drug users, why are they more at risk to suicide? One is, of course, acute substance use, where in a feeling of intoxication, the person gets very emotionally driven and takes something to end their lives. When they are sober, they would not have had this feeling. I used to see a lot of patients with alcohol intoxication. And who would, in the moment of intoxication, remember what somebody had said to them, and they would take an organophosphorus compound, vomit, and land up in casualty. When they got sober, they did not recall the fact that they had attempted to take their lives. And that is what intoxication or disinhibition can actually do. This is true not just of alcohol, but of several other drugs that I spoke about, cannabis, stimulants, psychoactive substances like, the hallucinatory substances like LSD, stimulants like amphetamines. They can all impair impulse control, impair judgment, and cause people to do something that might harm themselves. So one of the things is intoxication to the substance. And remember, this can happen just with the first use of substance or with an occasional use of substance, heavy use of substance. So this is something that cannot be predicted because the person has not been using substances over a period of time, has not had an addiction, and still is at risk to suicidality. Of course, we do know that people with chronic medical conditions and substance use. Now, substance use itself can lead to chronic mental conditions. Alcohol, we all know that alcohol can cause hepatic damage, can cause cirrhosis to the liver, can cause cancers, especially when combined with smoking. So the person has the use of chronic use of substances, develops a chronic mental condition, a medical condition, cannot handle the medical condition, and therefore is suicidal and upset. When a person has substance use along with depression or with a psychotic disorder, as I mentioned, the problem increases several fold. It's also very important to understand that there are possibly common genetic underpinnings of all these disorders. We know that people who are more prone to depression are also perhaps more prone to developing an addictive use of substances. We know that heavy uses of substances may have an underlying bipolar mood disorder or a depressive disorder. We know, for example, that cannabis, especially in people who are vulnerable to psychosis, can bring forward or cause a psychiatric or a psychotic disturbance to occur at a much younger age than it otherwise had done. So we've seen a lot of young people who had a family history of psychosis, who used cannabis at a very young age, and at 18 or 19 had a psychotic breakdown, landed up with us. Now, cannabis itself in very high doses can produce a psychiatric disorder. And in the absence of any risk to psychiatric disorder, that person may completely recover from the bipolarity or the mania or the psychosis. But if cannabis has brought forward a psychiatric disorder, a psychotic disorder, then especially in vulnerable people, this might be the beginning of a journey of psychiatric problems. And the use of cannabis further compounds the whole problem and can pose difficulties in management of a psychotic illness. And of course, the fact that, there's a saying that alcohol destroys the family long before it destroys the liver. So the psychosocial problems it produces, the interpersonal problems, the economic problems, they are all associated with an increased risk to suicide. So there are biological reasons, there are socioeconomic reasons, and there are chemical reasons as to why substance use is associated with, with the risk-taking in a person who's intoxicated. The ability of, the likelihood of risk-taking also increases several fold. The person's judgment is impaired, and therefore there may be more. Substance withdrawal is also a time where a person can become suicidal. We talk about deliriums that occur in people who are heavy users of substances. I remember a young boy with a cannabis psychosis. I mean, that's something that I can never forget in my life. He was a young chap with 22, with the nicest of curls in his hair. He got admitted for cannabis-related psychosis with his mother. His mother was watching him like a hawk. She was all the time doing it. We talk about eyeball to eyeball monitoring in such situations. We admitted him in the ward. He went into the toilet. The mother was actually standing outside. And he had been agitated, and he did not come out of the bathroom for about 5 minutes. The mother knocked at the door, and by the time we entered, he actually died by hanging. And therefore, I think what it tells you is that substance use can kind of make a person extremely impulsive and can cause problems. And this has been described with all kinds of drugs, whether it's cocaine, it's stimulants, whether it's inhalants. We do see an increased risk of suicide in persons who use these substances. Now, how do we prevent these problems? Of course, a universal prevention is making sure that people don't have access to methods of committing or dying by suicide or attempting suicide. And that, for example, one of the things that as a policy, making sure that people don't have access to pesticides very easily, changing the nature of the pesticides, not having access to medication very easily, because medications, when combined with intoxicants, can be detrimental and can cause increases in sedation, drowsiness, and so on. So I had this young man from Kashmir who was using multiple drugs, and he used to inject himself. What we made sure was that he did not have access to injecting equipment very seriously. I mean, even if he was using substances, the fact that he was not combining 2 or 3 injections together and causing respiratory depression, he actually went on the ventilator 3 times. The other thing that we told his mother to do is to provide him an antidote. You do get antidotes to opioids, for example, so that if you give the antidote, the respiratory depression can be prevented. The other thing, of course, is to strengthen protective factors in the community. I mentioned those protective factors: a sense of belonging, a sense of optimism, a sense of being able to reach out to people, social supports, very important. Now, we also need to do what is called selective prevention, that is being able to identify the warning signs of suicide, both the behavioral signs that we discussed and the emotional signs that we discussed earlier. And people who make any kind of ideations, we need to make sure we should not dismiss them as a passing phase. I think it's very important that we pay attention, we try and talk to the individual, we try and get the person to see a mental health professional and make sure that they feel supported. These are all very important aspects of prevention. Now, what can you do if associated with the substance use, there is a risk of depression or psychiatric illness? If the person has made a severe attempt, which potentially could have caused death as an outcome, you need to make sure if there has been a trigger event and the protective factors haven't been there, if the person has made a recent attempt and has recurring thoughts of suicide, an admission to a psychiatric facility is important. We need to remove the access to any measures of suicide. And we also need to have a close supervision by a confidant. Now, these are very, very important. And one of the things that we do when we admit a patient with suicidality, we do what is called eyeball-to-eyeball monitoring. We actually ask about suicidal ideation. In fact, a lot of people think that asking about suicidal ideation actually triggers off, thoughts of suicide. That's not correct. What we do is we tell the person to actually report if they have suicidal ideation. We might contract with the person that if they feel a certain way, that the only thing that they need to do is inform someone, so that that person kind of takes charge at that moment in terms of helping the person to overcome the moments when they're feeling so desperate. If the risk is moderate, the person has risk factors, but has some protective factors, but there has been no attempt, it's an ideation, we may admit, but most importantly, we may develop a crisis plan to help the person, make sure some confidant frequently checks in on the person. If the risk is thought as low, where a person might be having ideas about, that it's better off to not live, but has no plan, intent, or behavior, has strong might be managed on an outpatient basis with the help of a counselor or a mental health professional. So what I tried to tell you in the last few minutes are a few things. One is that substance use and suicidality have a very close relationship. Suicidality itself is a very complex phenomenon. Suicidality can occur in the context of substance intoxication or withdrawal or the chronic use of substances. People with psychiatric disorders are more prone to substance use, and people who use substances and have a psychiatric disorder are at greater risk for suicide. In addition to the prevention and the intervention, I need to tell you what we would do in a hospital and what is possible in the community. So obviously, in people who have vulnerabilities, and that's really the most important thing. It's not just about saying don't use substances. The first thing that we do is try and understand why a person uses a substance. Are they trying to overcome a negative mood state, to get over a relationship? Are they doing it for pleasure because they're not able to pleasure in anything else? So finding alternate ways of pleasure, and also finding alternate ways of coping and dealing with anxiety, depression, etc., becomes very, very important. The second thing is that people need to understand that the use of substances does not take away the problem that is underlying it, adds to a problem. So one of the things I tell a person is, if alcohol is causing problems, it's the problem. It's not taking care of the underlying problem. That's the second thing. They must know that substance use is not an effective way of coping with a particular problem because it adds to the problem. The third thing is for people at risk. For example, people who have a family history of psychiatric disorder, people who have a family history of substance addiction, and people who have, any kind of brain damage. The effect of alcohol and other intoxicating substances is much more on them. That's very important to remember. Young people who've had difficulties in their childhood in terms of adverse life events, in terms of domestic violence, in terms of growing up in difficult neighborhoods, are at risk to a variety of problems in later life, including substances. Young people who had childhood sexual abuse are also more likely to have substance use later in life. Comorbidity, that is, substance use is associated with higher rates of depression, anxiety, post-traumatic stress disorder, and so on. So the basic problem is that we need to be aware of these risk factors. Temperaments are also very important risk factors. Kids who are extremely impulsive, kids who cannot maintain attention on a particular task, cannot focus on a particular task, are hyperactive. We must make sure that we take care of those problems so that, because these kids later in life, if these problems are not handled, are at greater risk to use substances. And when they use substances, it's like a chicken and egg. The whole thing kind of aggravates one another. Similarly, young people who are extremely anxious, who don't, find it very difficult to mingle with crowds, have a lot of social difficulties, to make themselves feel as if they feel more courageous, may turn to substances to overcome those problems. Once again, neither does their anxiety and social difficulties go away. They just add another layer of problems to them. And that's what they need to understand. And of course, now we know that it's not only young people who are at greater risk to use substances. There have been several studies done in older people. We call it the empty nest syndrome, when there is nobody at home, your kids have all gone away and there is a lot of loneliness. When your spouse passes away, there is a sense of loneliness. When there is nothing else to do, people feel at a loose end. And there are people who might have stopped substances in between and restarted at an older age, or people who initiated substance use at a much older age. Obviously, as the brain ages, the brain is more sensitive to the effects of all these intoxicants. All these intoxicants are neurotoxic. They damage the brain cells, and therefore they may increase problems like cognitive problems or memory problems that people have. I've had people, I remember this gentleman from the army. He was in his mid-60s, and he came to us with what we thought was a dementia-like illness. So we thought he had dementia. Now, when we actually went into detail into his problems, we discovered that when he was in his 40s or early 50s, his son had died in a drowning accident. To deal with that grief, he started using alcohol. And he suddenly stopped his alcohol and he went into this kind of picture where he had recent memory problems. He was making up things, you know, he failed on all his memory tests. We initially thought he might have dementia, but we thought let's treat his alcohol dependence properly, treat his alcohol withdrawal symptoms properly. And as he came out of the treatment of his withdrawal, his cognitive functions actually improved. So he didn't have a dementia-like illness. The alcohol use and the withdrawal produced a dementia-like illness. So as doctors, we're extremely careful to try and differentiate the problems that are caused by the substance itself or by the co-occurring disorder or the comorbidity that the person might have. And that could be psychiatric comorbidity or it could be physical comorbidity. Persons who use alcohol heavily can go into what we call hepatic encephalopathy. Their liver can start to cause dysfunction and affect their brain. People who inject drugs are more prone to HIV, are more prone to hepatitis, are more prone to cardiac problems. Cannabis, I mentioned already. So each class of drugs produces a different kind of symptoms during intoxication, during withdrawal, and during chronic use. The other thing, of course, is the treatment for these disorders. It's not just medical treatment in terms of the medications to deal with withdrawal, to reduce the craving. We also do psychosocial interventions, establishing a good relationship with the person, separating the person from the addiction. That's very important. And trying to address the underlying causes for this and making sure we see the person on a continuous basis, because all these are relapsing conditions. A person may be well for about 6 months, a year, etc. And then suddenly when there is a crisis, the person may go back to taking the substance. The typical example I remember is patients who had been sober and been off substances for 5 years and 10 years. When Vishnuvardhan died, I remember we had a spate of patients who came in and because of the grief of the death of their hero had relapsed to alcohol. So, that's something that tells us that they need ongoing treatment. And of course, self-help groups like the Alcoholics Anonymous, the Narcotics Anonymous, the Smokers Anonymous are all facilities that are available in the community. And of course, are as important perhaps for people who don't have access to other services or get help from these kind of organizations to, this affiliation helps them to overcome their problems with addiction. So to me, I think it's important for people to understand that addiction is, when it happens, is a brain disorder, just like any other psychiatric disorder. People with addiction. People who are using substances must be aware that it's not a solution for anything else, that it can potentially cause problems to them and either not use it or use it in a very, very responsible manner so that they don't have the difficulties that come out of it. But finally, I think people must understand the risks that have come with excessive use of substances, chronic use of substances, and vulnerable use of substances. So I think it's important to look at the risk factors, the preventive factors, as well as the interventions that can be done. I'll stop here. I'd be happy to take any questions from anyone.
Thank you very much, Dr. Pratima Murthy, for this excellent presentation on suicide linking with various addiction behaviors. And we are grateful to you, MBA is grateful to you for covering this topic, because our World Suicide Prevention Day also coincide with this month program. So we were waiting for you to have this presentation, which has enlightened all of us, given us a lot of information, including covering the prevention, the area of prevention. Thank you so much. A number of appreciation, positive responses to your talk in the chat box. They all say excellent. Thank you so much. And two questions I want to start with. We will have about 15 minutes of discussion. So those who want to raise question, you can show your hand or you can write in the chat box. The first question is from Sorali. Can it be possible that southern regions have higher numbers because of higher number of reporting, as it is eventually an outcome of NCRB reports? Do you think there are any hidden numbers overall? First question for you, Dr. Murthy.
Yeah, I think that's a very good introspection as to why are the southern regions, is it just a reporting bias? That is, suicides are not reported in other states, partly perhaps, but also there is a suggestion that there is an increased prevalence of suicidal attempts per 100,000 population in the southern regions. And I think, for example, Kerala is one state where we do know that there are relatively higher rates of suicidality, and one might speculate on the socio-economic factors, whether migration, loneliness, use of substances, and many of these may be contributing factors. And therefore, I think this whole thing of looking at the socio-cultural determinants becomes so important.
Okay, thank you. The second question is, since social drinking among all genders are increasing in India, and America has already gone through this situation, does the case increase as the alcohol use increases? And what has America or developed nations done to get out of it?
I think I wish we had good lessons to learn from many countries. I'll talk about the example of smoking. In the United States, I think it was in the 1970s and 80s, the number of smoking-related deaths among men from cancers, from lung cancers, was steadily increasing between the 50s and the 80s. But when people started understanding that there is a link between smoking and lung cancer, and they started doing active campaigns in men, the rates of adenocarcinoma and smoking came down in men, but started to go up in women. Because women were not being targeted for anti-smoking messaging. And so it tells you that in different populations, depending upon how it is normalized, every country is waking up to the problems of substance use. In the United States, for example, there have been several attempts now, and they continue to be, school interventions, college interventions, workplace interventions, mothers against drunken driving. You have so many different kinds of approaches to look at it. Similarly, cannabis. Cannabis, for example, you'll be looking at the debate that in some states of the United States, in some of the states, they're looking at legalizing cannabis. But equally, there is some interesting research which suggests the opposite. That, for example, that people who are using cannabis, and these are some interesting stories from Canada, research in Canada, which says that people who use cannabis and drive actually cause more accidents. And why do they cause more accidents? It's not because they're driving very fast, but in a highway where the speed is a minimum of 50 or 60 miles per hour, they're driving at 10 and 20 miles per hour. Because they're so careful, they're driving so slowly that they're not allowing the other end. So you'll see that different countries have different kinds of problems with various kinds of substance use. There is a general law that as the use increases with any substance, the problem also increases in that particular country. So for example, in countries like France, which have the highest, per capita drinking, the problems with alcohol are also increased. And therefore, in developing countries, as socialization and the use of these at acceptable norms increases, the problems with these also increase. And that's something that we need to understand at a population level. So basically, a lot of states sell a lot of alcohol because it's a good excise. No, you might have watched, what's happening in some of this, debates recently of how alcohol becomes a source of revenue and alcohol policies can change. But the fact is, while you're getting money from excise revenues, the amount you're spending on the health, the physical health problems of people, on the accidents that are caused as a result of it, on absenteeism, they seem to outweigh any benefits that you get from excise. And these are debates at a political and a socio-political level. So I think there is that, and that's why it's so complex. The whole relationship is complex. The answers are also complex.
Thank you. Ma'am, the next question is, ma'am, how do we deal with habitual substance addictions at the community level?
Okay. So there are different things. I mean, at the community level, I think one of the biggest things is awareness. People hesitate. I mean, there is both a little stigma associated with reporting substance use. So one of the things we tell people, at least healthcare providers, is anybody who comes to any hospital, please ask them whether they use alcohol, whether they use tobacco, whether they use drugs, whether they use in the past or now, as part of a routine examination, so that it's not seen as a moral problem. It's seen as a public health problem. Okay. And then it's very important then to what we call do brief intervention. You ask about it. You advise them about the risks of continuing and the benefits of stopping. You assess their willingness to quit. And if they're willing to quit and have a mild problem of substance use, they can just be told what are the withdrawal symptoms to expect, and they can be managed at home. In fact, we encourage community workers to do that at home now. If it is severe dependence, we encourage them to get hospitalized so that they can be treated for their withdrawal symptoms. Because in some cases, like very heavy alcohol consumption, when they suddenly stop, they can get seizures, they can go into a condition called delirium. So if they're very heavy alcohol users, we advise admission and medical supervision to give up the substances. So in the community, while we can look at preventive programs, awareness programs, we also need to tell people that if they have an addiction, that they should seek medical consultation and treatment. Any hospital now, any medical college now will have a facility to help people. And we need to create a demand for these services. When you create a demand, the services also will improve. Of course, because people feel so helpless, one of the things they do is admit them to some de-addiction facility. Now, if the de-addiction facility is a facility which respects people, their human rights, etc., may be good. But we do know examples of people being thrown into these centers, treated in a very degrading manner, being punished, and lots of human rights violations. So we just need to make sure that that doesn't happen. And the only way we can do that is to provide facilities in the context of health, in medical colleges, in general hospitals, of course, have specialized de-addiction facilities. We need to have a variety of these facilities. In addition, some people are looking at to see if we can do a home detoxification for people. Should be possible, So we need to look at the entire range of interventions. But most importantly, in the community, prevention is very important, particularly in young people. Because people, we call them careers in addiction. Sometimes people start their careers in addiction very, very early. There are examples throughout the country of young kids in slums who are starting to inject drugs at the age of 8 or 9 because their father is, a father or mother is using substances. So I think in terms of making the community more resilient, of denormalizing substance use in the community, I think that's also very, very important to take up. And of course, mental health promotion. I mean, I think looking at helping people deal with their stresses, support each other, these are very important to make people, not turn to substances as the only way they know of coping. So these are all the community interventions that can be done.
Thank you. Yoshita She asked, thank you for your presentation, ma'am. You mentioned that normalizing talking about suicide in the community would lead to a possible increase in the rates in suicide. Considering this, how can we talk about suicide to spread awareness and support around it while maintaining a balance?
Okay, Yoshita, I didn't, yeah, let me just correct that statement. I didn't say talking about it normalizes it. Now, the way you report it, the way it is reported, if it is sensationalized, if it's reported in the front page, if it's talked about in that kind of, that is what causes problems. Talking about, that it's okay that you have these feelings, that does not increase the risk. So I think that is the difference that you need to understand, that so the WHO has guidelines on how you must report suicide. You don't say somebody committed suicide. You say people die by suicide, but you don't report the means, you don't make a big hoo-ha about it. You kind of, contain it so that, there are no copycats, kind of thing. It doesn't become an endemic of sorts.
Next question is, that's last from the chat box. Ma'am, how can we counsel family members of suicide loss, especially children who are traumatized?
Yeah, I mean, it's quite distressing, the stigma that's associated with suicide, because especially family members who've had a person who has completed a suicide, not only have the burden of loss and grief, but a sense of guilt and responsibility. So I think it's very, very important that they are supported, that they are allowed to express whatever feelings that they have, that they are, given the right kind of psychological support. They're evaluated for any kind of severe distress and so on. Somebody commented that even educated people, education and suicide have a very complex relationship. While, as I said, poverty and lack of opportunity is a risk, higher education is not a protective factor, because there are so many other mediators that can, that can be influencing the way a person's emotional state is and their impulsivity and their risk. So there is no correlation between just the fact that you're educated and the fact that you need not be, taking umbrage in these kind of eventualities.
Thank you. We have one more question. As you said that this is from Victor James, as you said that even high educated people also thinking about suicide, how can we get advice to this educating generation if the education failure to rescue them from suicide?
No simple answers to that, but I think what we must understand is education is not just knowledge. When we educate, particularly when we educate people in schools and colleges, we also need to educate them about social competency, about what we call life skills. How do you communicate with each other? How do you cope and handle difficulties? How do you become resilient? How do you dream big, but if your dreams are not fulfilled, how you don't crash to the ground? So I think all these things also need to be part of one's growing up and one's education. And somewhere, I think as a society, we need to do much more of that. And that's the only way you can make people more resilient over time.
Okay. Any hand? Anybody want to ask a question? Any hand?
Dr. Joseph, there was one Mr. Matthew and Dr. Ajit who have raised their hands.
Okay. Before that, COVID has, this is from Matthew. COVID has possibly increased alcohol and drug abuse and suicidability, a very vicious cycle of aggravation of both problems.
Yeah. So I don't know if you have been following the literature. You know, when the 9/11 problem happened, there was an increase in the use of alcohol in many communities which were affected. Similarly, any kind of catastrophe does tend to increase the use of alcohol. So also during COVID, I mean, during lockdown, there was no access to alcohol, but all of you saw what happened the moment the lockdown was lifted, the queues in front of the alcohol, kind of outlets. I mean, it was crazy, and the whole media was kind of talking about it. So, and there are several countries where there have been reports about increase in alcohol use, increase in drug use post-COVID because of the loneliness, because of the stress, because of the grief that occurred. So you can be sure that many of these things, we also interestingly found an opposite effect. For example, people who were smoking, and they actually, the calls of people who wanted to quit smoking, who were serious about quitting smoking, the percentage of serious callers to the quit lines increased. And the rates of quitting increased from about 17% to about 30%. So, there is also a difference in that where epidemics, where there's information that the infection affects the lungs can motivate people to stop. Ajit, I'm sure you can also, I'm sure there are aspects I haven't covered, which you might, also add to.
Thank you. Samuel Mohan, is suicide rate less where prohibition is in force?
Very interesting question. Perhaps. I mean, I don't know specifically about suicide rates. That's worthwhile. I mean, I think that's a worthwhile thing to actually research a little bit. But all problems related to alcohol have been shown to reduce. Now, the problem is what happens. So prohibition to alcohol might reduce some problems. But what happens to people if you don't help them to deal with, their lives? It's likely that it might change to something else. It's likely also that we do know that prohibition is something that is not very easy to sustain. And that's a problem. So prohibition by itself is a very limited answer. It is when there is restriction of substance use associated with a whole lot of other developments in society that you might be able to overcome the problem.
Thank you very much. I was just glancing through the chat box. More than 60 people said appreciation, excellent talk, and requesting for the audio, which Rohini said we will provide after editing. And so now over to Dr. Ajit, the final question and conclusion of the discussions.
No, Pratima, I have nothing to add to what you said. Thank you for a very wide canvas covered. I particularly wanted to emphasize the point you made about rehab centers that do not even have a mental health profession on their staff. They are apparently licensed and they engage in inhuman treatment of people. Is there any forum where we can complain about such people? Because several of the people who go there are prone to more disturbed behavior, including suicide.
Yeah, I mean, you can complain to the mental health authority because they are supposed to have mental health care professionals. They are supposed to be licensed. So you can complain to the mental health authority. People have put in public interest litigations. You can write to the health department. I think it's important to raise consciousness about the fact that people should not be mistreated. Addiction is not a crime. It's a disease, and people need treatment, not incarceration and human treatment. That's very important to convey.
Now, if we have a backing of somebody like you to emphasize that, it'll be a great impetus to proper action.
Yeah.
Thank you. Now, the last two questions, one from Hema and one from another friend, both linked to the same area. Would it be a good idea from Hema? Would it be a good idea to have coping mechanism workshop before major exams in schools as we read so much of kids being unable to cope with. That is one. And the second one, how to help to cope to prevent teenagers to prevent suicide. Both are linked questions. That is the last, and that is the last question for you, Dr. Murthy.
Yeah. So one of the sad things that I find is that, that because of the pressure of an examination, a kid has to think about this as an option. I mean, so somewhere along, I think we need to think about how, what kind of gravity we've given examinations that a kid who can't cope with that must think about that. Also the state, I mean, I remember that we were asked to start a helpline before the examination so that kids, but we need to work with parents to help their children to deal with this. We need to look at educational systems and teachers to see how best they can prevent this kind of thing. We also need to, as a society, recognize that there are going to be people with different kinds of abilities, and failure or passing in an examination is not the only hallmark of somebody, being a failure or successful in life. That's a very difficult thing to do, because all of us kind of have certain expectations from ourselves, from our children, from society on what is, success and what is failure. So I think that's important. As far as teenagers are concerned, again, I think working with young people, I believe that a lot of young people have wonderful qualities. We need to nurture those qualities, but at the same time, in a brain that is not completely matured, judgment is something, impulsivity is something. So if we can work with these guys, and several of my colleagues in psychology have been working with students in college to look at how do they improve their mental health, how do they learn to manage time, how do they learn to manage relationships, the so-called life skills. Those are important ways of engaging young people. And young people are more likely to listen to peers rather than to family members, especially during their teenage years. So perhaps having peers who that's something that they're doing in some of the colleges, getting peers to kind of be the support for young people, somebody whom they can, they can discuss their problems with. Helplines, using technology to reach out to young people, having ways they can just, WhatsApp somebody or, send out a message to somebody and get some help. There are lots of young people who are doing their PhDs who develop videos that can help young people to kind of identify with and overcome their problems. So there are lots of things that we need to do, but I think working on self-esteem, self-confidence, not needing to need drugs to enhance yourself. The other thing is, when I talk about drugs, I forgot to mention some of the performance-enhancing drugs. That's another problem. You have a lot of people who go to gyms to bodybuild, and they're taking steroids as part of the whole thing. Now, we've had a couple of kids who come with steroid rage, because again, these are all chemicals that alter the brain. And therefore, I think young kids need, again, to be cautioned that, we all need to be aware that sometimes some of these bodybuilding things, sports enhancing drugs, etc., can also be problematic in terms of producing various kinds of negative reactions.
Thank you very much, Professor Pratima Murthy, for this excellent presentation, as well as very informed and practical, clinical discussion on practical and clinical matters to the grassroots level. Thank you so much. Over to Rohini.
Thank you very much, and all my good wishes to MPA.
Thank you so much, Dr. Pratima. Thank you for this wonderfully enlightening lecture, and everybody's impression has been the same. We're really, really privileged that you came and spoke with us on this topic. Thank you, Dr. Joseph George, for moderating this and sharing the session for us. May I now request Tilaka ma'am, who is our current managing committee member, to please give the vote of thanks and before we can all disperse for this evening. Over to Tilaka ma'am, please. Mrs. Tilaka Bhaskaran. I can unmute you.
It is my privilege to express gratitude on behalf of the MPA team to Dr. Pratima Murthy. Thank you, Dr. Murthy, for taking so much of your time to talk on this very relevant topic today. Thanks for highlighting all the problems involved in substance abuse and its relationship to suicide, and on how to help or get help. You have covered most of the things that we needed, and I think you have very effectively cleared the doubts that people had raised for you. Every morning when we open the newspaper, we read about kilos of cannabis and other drugs confiscated in different airports and ports. I read today that the official figure of the use of cannabis is about 2.8% in the country. This is statistics that was given for 2019. How is the country going to deal with this is something maybe we will have to think about. The critical factor in events such as this is the support of the sponsors. We thank Microlabs for their generosity, especially Mr. Ganesan and Mr. Nawaj. And thanks also to the team of IT people who conducted this Zoom meeting for us. Thank you very much. We appreciated every word of what you said.
Thank you, ma'am. And I'd just like to express my thanks, of course, to the MPA, but also to my young colleague, Dr. Jayanthi, to help me with the slides, and a young colleague sitting here from the mental health education who actually ran the slides for me. Thank you all very much. Bye.
We hope you will continue your association with MPA, Pratima.
Of course. Of course. Yeah. I have some very fond patients of mine who stayed in the MPA, whom I saw for almost 40 years. So thank you very much.
Till now, you were only a name. Thanks for seeing you.
We must have you over.
Yeah.
Sure.
And meet our staff and residents.
Yeah. Thank you.
Thank you so much. Thank you so much, ma'am. Thank you so much, Tilaka Bhaskaran, ma'am. Thank you so much, participants. We've had 118 people who logged in from all across India, including Jammu and Kashmir and Kanyakumari, which is like an excellent, yes. And we're really, really pleased that all of you could join us on a Saturday evening. I hope you have a wonderful weekend, and please feel free to log out. Thank you so much. Have a good evening.
Good evening and thank you.
Have a good evening for everyone.